This conference will now be recorded.
Good afternoon, everyone. Thank you so much for joining the March Healthy Happens Here series. Today, we will go ahead and get started at 2 p.m. So we're just going to give it a few more minutes for folks to join us.
Manden ahora algo allá atrás. Por favor, solo por si acaso me dicen. Oh, I think I'm on speaker. Sorry.
Good afternoon, everyone. Thank you so much for joining today's Healthy Happens Here series. We're going to go ahead and give it a couple more minutes as we have some more folks joining us. Thank you so much for joining us today. Good afternoon, everyone. Thank you so much for joining us today for the Healthy Happens Here series. We're going to go ahead and give it just another minute and we're going to get started. Thank you all so much for joining us.
Mira, luego ayuda.
Good afternoon. Welcome to the Healthy Happens Here webinar series. Thank you all for joining us. This is a series of virtual webinars that cover a variety of health topics, including nutrition, mental health, tobacco cessation, and chronic disease self-management. My name is Candace Schottenlohr, and I am a health educator with the community engagement team here with the Florida Department of Health in Miami-Dade County. And today I also have my colleague, Brianna McDaniel, who will also be joining us today to help assist with this event. Today's event is called Colorectal Cancer Awareness, and during this webinar, we will have a presentation on the importance of regular physical exams to prevent colorectal cancer. You also have the chance to learn about what colorectal cancer is, how to lower your risk, signs and symptoms, and the current screening tests available for colorectal cancer. There will be an important emphasis on regular physical exams, including complete examinations with the appropriate labs to ensure patients are staying focused on living healthy, active lives. And a key focus that will be highlighted is really the importance of educating patients on how to avoid unnecessary emergency room visits and hospitalizations. In addition, we'll also have a Q&A session with our presenter today, immediately following his presentation. And during this webinar, please feel free to enter any questions you may have in the chat box, and we'll address as many as we can during the Q&A session. And just some other reminders before we go ahead and get started. You have the capability of having your camera on or off, and to mute and unmute your microphone if you want to ask any questions during the Q&A. And just as a reminder, if you're not speaking, please remember to keep yourself muted. And so now I would like to go ahead and introduce our speaker for today, Dr. Humberto Jimenez from Optum Clinic. As an Optum Clinic physician, he focuses on preventative care, and the medical staff at Optum Clinic coordinates your care from start to finish so you can get the same care no matter the situation. With our support and guidance, you are empowered to make the right health choices for your lifestyle through routine visits, health screenings, and vaccinations. Mr. Jimenez received his education from St. George's University in Granada. He did his medical residency at Montefiore Medical Center, Albert Einstein College of Medicine in New York. He is board certified and has his specialty in family medicine. I will now turn it over to Dr. Jimenez. Thank you so much.
Thank you so much, Candice. I'm happy to be here. Happy to be part of this endeavor. I think it's very important that every patient is made aware of ways to prevent illness, ways to catch it early, and I'm happy to be involved, especially in this month. It is colorectal cancer month. Now, of course, when we talk about colorectal cancer, most people refer to it as colon cancer. So a lot of people understand that has to do with the digestive tract, but maybe they don't really understand exactly what we're talking about. So we're going to focus today on the things to look for, the conversations to have with your physician, ways that we can assess for colon cancer, and the reason that we should. So next slide. Okay. Give me 1 second. So again, my name is Humberto Jimenez. I am board certified in family medicine, meaning that my specialty is a 3-year specialty in the fields of internal medicine, pediatrics, and OBGYN. So I'm very familiar with all of those topics. And as a primary care physician in family medicine, we focus on heavily on prevention. So that's our bread and butter. And these conversations are things that we have almost every visit with our patients. So I am the lead physician at Optum Westchester. We are currently at 7775 Southwest 87th Avenue, so right by Norman Brothers. In case you guys are looking for physicians, we're there. Okay. So disclosures, I do not have any financial disclosures or relationships to discuss. The objectives of this talk, which I alluded to a little bit earlier. So what is colon cancer? How common is it really? Who is at risk and needs screening? Why should we screen for colon cancer? How do we screen? What are the methods that are used? Is it painful? Is it risky? I know that there's a lot of concerns about the actual procedure of colonoscopy itself, and we will get into those details. But you also find that there are other ways to screen, and you will be able to speak with some knowledge with your physician about what is the best way to screen you for colon cancer. And then what are some prevention strategies that are used to prevent colon cancer? Okay. So the colon, first of all, I want us to be familiar with the area that we're talking about. We are talking about the colon, which is subdivided into 5 parts. It begins in the yellow area, the cecum, then extends upwards in the ascending colon, goes through right underneath sort of your rib cage in the transverse colon, and then goes down on your left side in the descending colon and ends at the sigmoid and then the rectum. The rectum is sort of the vault, is where poop is sort of compacted. It sits waiting to be voided. And the purpose of the colon is to water and salt absorption. And um, now this is a colon cancer surveillance talk. So how does in fact this cancer begin, right? How do we get to a point where we have cells that are undividing or dividing without control? So they first, what we have is a bit of a mutation that produces a polyp. So a polyp is basically, and this is a little bit simplistic, but essentially here you see a little, if you look at the picture on the right bottom, there is a little ball that looks like it's connected by a stalk. So that is a colonic polyp, and we use that anatomy to our benefit in colonoscopy, and we'll get to that. So polyps are outgrowths, right, and have the potential of becoming cancerous. They generally will mutate, will begin to change at the surface, which means at the edge of that little ball, and then will extend towards the stalk and into the colonic wall. So the idea of surveillance is to catch these things early and remove them. Now, what you're seeing there is a tubular adenoma. It is the most common type of polyp. There are other things such as hyperplastic and villus polyps, all sort of like, things for the gastroenterologist to worry about, but really beyond this talk and not really relevant for most people. The idea is that we have these types of polyps and they are potentially removable. The other thing about, if you'll notice, is that we just have a little growth, kind of like maybe akin to a skin tag that some people have. You notice either on their neck, on their underarm, that kind of thing. Those things do not cause symptoms. You're not going to have a person complaining of abdominal discomfort or diarrhea or anything like that. So the reason that we begin to screen early is because we have an asymptomatic condition that has a high propensity or high potential of becoming a cancer or an invasive tumor. Now, next slide. All right, one second. Right. So this is the natural progression of a cancerous polyp. First, you have a stage 0, which is, it has not invaded into what's called the basement membrane, which separates that interior lumen part of the intestine and the actual wall. Then you have a stage 1. It begins to invade. Stage 2, we see a bit of extension into what are lymphatics. Stage 3, we see lymphatics and also blood vessels involved. And then stage 4, of course, is that dreaded metastatic disease that nobody wants to find. The idea is to catch things early, catch it at stage 0, and prevent all of this sort of heartache and disease that can develop quickly. Okay. So next. All right. So how common is it? And I apologize for my slide. I think is it pointed colon cancer? Perfect. All right. So if you look at the incidence rates of colon cancer, that is new cases of colon cancer a year, this is for 2020. We have colon and rectal cancer to be 9% in males, and we see it 8% in females. That makes it the third most common cause of cancer, and therefore something that we need to target in order to have people live longer and healthier lives. If you look at the estimated deaths, again, colon cancer is very high up there. It is 9% in males, 9% in females. So, again, the third leading cause. However, if the two of the cancers that are in position number 2 is prostate and breast. So overall, looking at men and women, colon cancer would actually move to a second spot, number 2. If you were to add those together and have it be 18, it'll be greater than the 15% that have breast cancer and the 10% that have prostate cancer. So it is something that we need to take very seriously. All right. So who is at risk, right? So who are the people that we're going to target? Who are the people that need to get colonoscopy? So with risk, as physicians, we always look at things that are inherent risk or non-modifiable risks that don't change over time. They're sort of, due to sort of fixed factors. And the first one that is of most concern is, of course, age. That is one of the things that we look at when we're considering whether or not somebody needs a colonoscopy, is that how old are they? Looking at the incidence data, we've seen that most people who develop colon cancer are above the age of 50. So that has been considered for a long time the sort of cutoff point of when somebody needs to initiate surveillance. So we have here, so over the age of 50 is a risk factor for colon cancer. But of late and recently, we've seen that people in their 40s are increasingly presenting with colon cancer symptoms. Therefore, and we'll talk about this a little bit more in detail further, there might be a real cause for dropping that screening age down a little bit. Now, the other thing is race. For multifactorial reasons, African Americans are at greater risk than our white, Hispanic patients, Asian. So that is a risk that we take very seriously, and informs when we screen. The other people that are at risk, of course, people that have had a previous history of colon cancer. These people are at higher risk. If they have a family history of colon cancer, family history meaning not just your mom, but your mom, your dad, and your siblings, the first degree relatives, so people in your immediate family, if they've had colon cancer, then that puts you at higher risk, and it warrants a conversation with your physician about screening. Now, inflammatory bowel disease, such as ulcerative colitis and Crohn's disease, which causes chronic inflammation of the mucosa of the colon, can also set the stage for a transformation or a mutation of the tissues, and therefore puts that person at risk for colon cancer as well, as does radiation, right? We always talk about how we want to limit the number of CAT scans and things that we do for patients, and here radiation for a previous cancer can potentially cause transformation of the bowel and can lead to colon cancer. So it's something that we always have to think about. And then there are the things that we do have control over, the modifiable risks. So things like people who have low fiber diets are at greater risk of developing colon cancer. So and they generally are coupled with high fat diets. So low fiber, high fat together. Those people are not eating well, right, by many standards, and therefore those people are at higher risk. So take home, watch your red meat intake, make sure you're not over consuming red meats. Obesity is also another modifiable risk factor. So diet and exercise always comes up, right, with heart disease, with many of these preventable illnesses. We talk about lifestyle as a way to stave this off. Now, diabetes, of course, some people have genetic predisposition for diabetes, but that's a whole nother story. But most diabetes type 2 are sort of linked to diet and exercise, so that too is a modifiable risk. People who have a sedentary lifestyle, people who don't get out and exercise much, those people also are higher risk. Smoking, and then heavy alcohol use as well. Now, sorry, okay. So who needs screening? Well, so here's a case of someone who was screened and diagnosed with colon cancer. I think maybe a little bit late because I think he was diagnosed at stage 3. But Chadwick Boseman, also known as the Black Panther, uh, unfortunately succumbed to the illness and passed away last year. So but who is at risk, right? Uh, so who should be screened? People who are considered at average risk, right? And so average risk determined by age, family history, and individual's associated health conditions such as diabetes and whatnot. So your primary care doctor, should be reviewing with you not just your own personal history, but also should be speaking to you about your family history, because that does inform when we and if we need to do a colonoscopy earlier, or if we need to screen in another way earlier. Right, but at what age, right? Like, this is the big question. It's always been a debate about when we should begin to screen patients. The so the American Cancer Society has been very vigilant about cancer in general and colon cancer in particular. The recommendations start at the age of 45, and it should be screened up to 75, and that's a recommendation they made in 2018. The United States Preventive Services Task Force, which is a regulatory body that determines when we should be screening in the United States as a whole, they recommend the age of 50 to 75. They did in 2016. They have a new recommendation, so a draft recommendation that is up for review at this point, that was published last year, that they want to drop the age to 45. And that's what's considered a grade B recommendation. So grade A recommendation is 50 to 75. That has the highest evidence. That means that doing that intervention is definitely going to save lives. And dropping it down to 45 is a grade B recommendation, which is actually not bad at all. So there is high evidence that we will be saving lives as well. So it probably will be dropped to 45 as the age that we will screen everyone. The American College of Gastroenterology recently, this year actually, dropped their recommendation to age 45 as well, from 50. And then when do we stop? So after the age of 75, there's every medical decision that we make is always a risk and benefit analysis. Is the intervention worth the risks that are associated with it? With patients who are over the age of 75 sometimes, and depending on how they've lived their lives, right, how healthy they've been, if they have a good strong colonic wall, they may not be a greater risk for perforation or such, which is extremely rare, by the way, to occur. But so the risk might be so low that the benefit, if they have a high life expectancy, might be quite high, and we might choose to go ahead and and have that patient have a colonoscopy, or go by another screening method. So that's a conversation that's had between physician and patient, right? Doctors don't no longer just make recommendations and you follow. I mean, there should be a conversation that happens between you and your provider so that you can come to a conclusion about what's best for you. Now, the higher risk population, African Americans, they should start screening at the age of 45, and that's a recommendation by the MSTF. And family history of colon cancer or associated diseases such as ulcerative colitis and that kind of thing, they have to begin screening quite a bit earlier, and that determination is made by the clinicians caring for the patient. A lot of times, the gastroenterologists will be the ones to determine how and when and what frequency we're going to use to screen that patient. Why do we screen? Like, what difference is it going to make? So we look at survival rates, right? And we look at that if patients are diagnosed with colon cancer with localized disease, meaning if you remember that picture that I showed you, 0 or 1, or you have a 5-year survival rate of 91%. So people without any symptoms whatsoever being screened and have localized disease, those people have a great survival benefit, right? So after 5 years, they're still alive and doing well. Now, if you get a little bit more invasive regional disease, then there's a 72% survival. And if you have distant disease such as a metastasis, that kind of thing, the survival rate is 14%. So it's pretty devastating and a pretty aggressive, cancer altogether. So the idea, as with many other illnesses, right, we want to make sure that we control the illness process very early on, or prevent having to lament, really, that somebody has progressed so far. And so 1 in 3 cancer deaths can be prevented with earlier detection, and that's the important piece of take home that I want you guys to have. All right, so how do we screen? We have basically 2 different modalities. Or 2 big groups. There's the stool-based testing. There's a fecal cold blood test, which is basically a card that you're given, and you have to take samples with 3 different stools. Uh-oh, something happened. Okay. So you have to check 3 different stools and mail that in, and that will determine whether or not there's actual just blood in the stool. Then there's actually it is trying to detect blood, but a lot of times it can detect heme. It's detecting heme, so a lot of times iron can give you a false positive, and it can be a bit less telling than the next test, which is the FIT test, the fecal immunochemical test, which is what we preferably use in our practice, because it doesn't give us the error of iron or any other things that might interfere with a true positive test. And then I don't know if you've seen commercials for Cologuard. That's a DNA test. It's a FIT DNA test. They're looking for DNA of stool DNA of cancer in the stool. And then the direct visualization tests are the CT colonography, which is basically a CAT scan, and then FlexSig, which is it's rarely done. I think it's more available in communities that have restricted access to gastroenterologists. So a lot of family physicians will perform this procedure. In Miami and in South Florida, really, we have very good gastroenterology teams. So we opt often for colonoscopy and use that because it is the gold standard. So okay. So again, colonoscopy. So we do this in an ambulatory surgical center or in the hospital. So a little clinic that all they do is these types of procedures. You do have to take a bowel prep prior to the procedure. A lot of people think that is probably the most problematic part of the process, is that you basically have to induce diarrhea so that we can clean out the colon well. We can look at the colonic walls. The good thing, though, is that, and I think it's one of the things that people get worried about, is that they're going to feel pain, or it's just going to be uncomfortable. And the reality is that you're sedated. And in Miami, this is not just done by a gastroenterologist alone in a room. We have anesthesiologist there that would administer conscious sedation, so that you can comfortably endure the procedure and forget about the process even. And so what is used is a little colonoscope, which is what you see there in the diagram. It's just a little tube that has a light and a little instrument that can kind of snare the polyps out. And it's flexible and can move to the colon easily. Again, very small risk of infection or bleeding or colonic injury. Okay, so next slide. So is it painful? No, you're sedated, as I said. And 8 out of 10 people said that it was less uncomfortable than they thought. And many studies have actually been done about this because it is something that we're concerned that whether or not people are going to do. So patient satisfaction does show that people are willing to kind of go at it again for follow-ups and things. So not that bad. In fact, I've had a colonoscopy. I can tell you I didn't feel anything. Okay, slide. Okay. So the thing, bringing things home to 2021, I mean, so COVID is happening, and do we really want to subject ourselves to a screening process that involves us, kind of leaving our houses and going into these places? And there's been a lot of guidance from the CDC about how these things need to operate to maintain a safe environment for patients. And so here are some of the recommendations and protocols for you to look at. Again, it's a lot of the things that we're doing in the office. Some places go as far as screening people with a nasal swab to confirm that they're not that they don't have COVID. Next slide. All right. So, and how often do you do a colonoscopy? Well, that really depends on what they find. So here is just a small table showing how often it's done. If your colonoscopy is normal, it doesn't have to be repeated for another 10 years. If you have 1 to 2 tubular adenomas less than 10 millimeters, 7 to 10 years, and so on and so on. So for the most part, people who have a colonoscopy and everything is okay, you're not going to see your gastroenterologist for another 10 years unless you have any issues. Sorry, next slide. Now, the second test, the one I alluded to as the one that we use in our practice, is the fecal immunochemical test, the FIT test. Now, this is, again, it is the second most common test. It is collected at home, and you're looking for small amounts of blood in the stool. That could be a sign of colon cancer, but it can happen with hemorrhoids, blah, blah, blah. So really not the gold standard, right? Here, you're already introducing possible confounders or reasons for why that test is not 100%. Then it has to be performed yearly, right? Because you're really depending on, you can be potentially having a bleed at that point or not, and still have a lesion there. And then if the FIT test is in fact positive, you will have to go ahead and undergo a colonoscopy to extract any polyp, any bleeding polyp, or look in fact for cancer. And how these things changed over the years. First, we had the fecal blood test, the one I told you about that can sometimes give us false positives. Then we have the FIT test. Again, this one is one sample rather than 3 different bowel movements, and there are no dietary restrictions with this one. Doesn't matter if you're taking iron. And then stool DNA, so that is the Cologuard. So you also know it's only one sample, no dietary restrictions, and it's more predictive in the sense that it's not that time dependent as the other ones are. You don't have to be bleeding. Excuse me. You will always be shedding some of the mucosa. into the stool. All right, so this is a fecal DNA test. This is the Cologuard, 92% sensitivity, and you repeat it every 3 years, and it's an important point to make. Again, if the Cologuard is positive, you do have to undergo colonoscopy, and it's increasingly being covered by insurers and Medicare. And then finally, just a quick slide about CT colonography, only because people get really excited about the fact that they think that if they have a CT scan, they don't have to undergo a procedure that is invasive, quote unquote. And I want you to be aware that CT colonography also depends on a clean colon. So you do have to take a prep. You have to empty your colon of all feces. And then the day of the test, they do put a tube in the rectum just to have air blown into it so that we can expand the walls of the colon enough so that we can look at them and analyze them in a good sort of 3D rendering. So it does take, so it's not as easy as just, a regular CT, abdominal CT that one can have in the emergency room. This is a little bit more involved. But it is quick, 10 to 15 minutes, but after you've done the whole prep and everything that really you have to do for a colonoscopy anyway. And the other thing about the CT colonography is that really is dependent on the center that is reading it. So you definitely want to make sure that it is done at places where where they perfected the read, where they're doing a lot of them basically, so they know what how to read them properly and give you some true results. So in Miami, it's good. I wouldn't go someplace in Wyoming and try. Just someplace that is not going to have a dense population and therefore not going to have that many tests being done, and sort of kind of hang your hat on the read that you get out of that. And I don't think that they would want to do that either. All right, so again, it is Colon Cancer Awareness Month. I want to make sure that with this talk, I've empowered you guys to know about what the risks of cancer are, how we go about screening, and hopefully you have a little bit more to speak to your doctor about next time, and maybe bring up relevant positive thing or relevant information, like if somebody in your family has developed a cancer, be it colon or otherwise. That is something that a lot of people don't really remember or think is important, but in fact it is hugely important, especially when we're talking about colon cancer, and will change when your doctor will want you screened. So it's important. Now, so that conversation with your gastroenterologist or your primary care doctor, and then I would be remiss to sort of leave the talk and not give you some signs and symptoms of colon cancer itself. The purpose of this talk isn't to just to scare. We're trying to do prevention here. By the time somebody has symptoms, it's really at that point we're not really. Yes, technically you would be screening for the illness, but you're trying to make a diagnosis at that point. So here are some local symptoms. So some changes in bowel habits like diarrhea, constipation, abdominal discomfort, bloating, nausea, vomiting, those kinds of things. Also, unexplained fatigue and significantly, significant weight loss is always a problem. It always requires investigation. As humans are more likely to gain weight than they are to lose, and so when we're losing weight and we're losing weight without cause, without trying, that really merits an evaluation by your doctor. So it's something to bring up, something to make an appointment for, and of course, loss of appetite. These are things that happen well into the advanced disease. So I hope that I helped you guys, to understand this topic, and I hope I've empowered you to, to get a colonoscopy and not be afraid about about what it means, and speak to your doctor about whether or not the FIT test is something that you might benefit from. Is it is Cologuard an appropriate test for you? And that's a conversation to have with them based on your risk. Again, Cologuard is not for high risk individuals. That's only for people at average risk. Okay. So thank you for having me. I don't know if you have any questions, Candice.
Thank you so much, Dr. Jimenez, for that insightful presentation and sharing how important it is to be an advocate for our health. And so at this time, I'll go ahead and turn it over to Brianna to go ahead and facilitate the Q&A for today.
Thanks, Candice. So I have a few questions that were submitted to us before and also during the event, and then we'll also check the chat box. If you guys have any questions, please feel free to submit in that chat box, or you can just unmute yourself. The first questions that I have here is, are there any available options for screenings that are just not as invasive?
Yeah, so I mean, the good thing is that we do have a lot of options. And as I mentioned, there are stool-based studies that don't have any they don't have to penetrate into the rectum to be able to screen. But again, they're only really appropriate for certain types of patients, and they have to be done with certain regularity that for instance, a colonoscopy does not. The benefit of having the colonoscopy is that it's not just a diagnostic test, but it can actually be curative, because as we mentioned, with those polyps that grow in the colon, that where colon cancer originates, we do want to have the best shot of being able to remove them, to extract them, so that colon cancer does not have the chance of developing. But yeah, they are, absolutely.
Thanks for that. The second question that I have here, are there any specific guidelines for screening adults who are between the ages of 76 and 85 years old?
Yeah, so I mean, it really is a conversation to have with your provider. There are certain people that fall in that age range that would be considered higher risk based on family history and whatnot. And so those people, that risk and benefit question, that pendulum kind of swings towards an increased benefit of a colonoscopy. Given that the risk of colonic wall injury is very low, so we would most likely opt to screen that patient. Now, people who are in medicine, we say, are like a healthy 75-year-old versus somebody who might have, unfortunately, many comorbidities, and so those people we look at, how, what their expected life expectancy is, right? And so if it looks like somebody might live well beyond their 90s, then you definitely want to be more proactive about screening that patient as to somebody who, might have very advanced cardiovascular disease, multiple stents, and, unfortunately is just, is not doing well. And so the risk of death for that person, unfortunately, is higher. And we probably wouldn't want to be doing invasive colonoscopies on those patients. But if somebody has a very long life expectancy, I say definitely have that conversation with your gastroenterologist and your primary care doctor, because you probably would be somebody that would benefit a lot from colonoscopy.
That was a great answer. Thank you so much. We also received quite a few questions about laxatives, such as, should we take these more often for the purpose of cleaning out your system? Are they beneficial?
So I mean, that's a little bit of a different topic, but we do definitely use laxatives for the purpose of cleaning out the colon for colonoscopy. So constipation, so chronic constipation or episodic constipation can occur. Um, the mainstay of treatment of constipation is, of course, increasing your fiber intake. Again, going back to your diet, increasing your water intake, because like you saw in one of the slides, the colon is involved in shifting water back and forth into the stool, softening it and whatnot. So you definitely want to be well hydrated. The more bulky your stool is, the easier it is for you to have a regular bowel movement. Now, sometimes we get into problems with people who take certain types of laxatives because they can cause, electrolyte imbalances. So we say, try to stay with things that won't do that, won't alter electrolytes, such as like Miralax. Um, if you need just a stool softener, so Colace. All these are conversations to have with your doctor because, again, constipation I mean, if you're dealing with constipation as a chronic problem and you've had that since you were a child and it's sort of like, the thing for you, not so scary. But if you've never had a constipation issue and all of a sudden, you know, you're not able to go, and then that could be a sign of that you need to, be evaluated for, whether it's IBS, whether it's um, colon cancer, whatnot. I mean, it's important to reach out to your primary. But yeah, but so things to avoid. So don't drink things like mineral oil or those kinds of things that they're very harsh. Just increase your fiber intake if you're having issues. Drink your water. Consider Miralax, which is gentle and will not cause any electrolyte abnormalities. Okay.
Thanks so much. I do see a question in the chat box, and they're asking if you can just touch on periodic detox.
Periodic. So you mean like colonic irrigation?
I am not sure. So this was by Nick here. If they could explain a little further, then we can make sure we answer your question properly.
So I know that a lot of people think that you have to go through a certain process of detoxing your system from the consumption, right? From your foods or drink or whatnot. There isn't a whole lot of data to suggest that that is any more benefit than allowing for your system to naturally do what it's designed to do, right? We have the liver that that is designed to detox, and we have the kidneys that also play a role in that, eliminating toxins. If that is what they're referring to, I'm not in favor. And again, I have to speak um, from the lens of a boarded family physician. I'm not in favor of things for the purpose of detox because there's not enough evidence to suggest that they actually do work. So eating a clean diet, I think, is probably the best way to go. Eating whole foods, and staying away from red meats, uh, and refined sugars. I think it's probably, sort of the Mediterranean diet that we all hear about, um, is probably the best way to not get into a situation where you feel you need to detox what you've eaten.
Thank you so much. The very last question that I have here, if you can go over this one more time, what are some helpful tips and recommendations that I can do to reduce my risk of colorectal cancer?
Right. So behavioral stuff. The number one, well, behavioral things. So as primary prevention, right? We don't want to primary prevention of a polyp. It's kind of impossible. But primary prevention, because we know that the colon cancer is associated with these risks. We want to make sure that we stay out of these risk groups, right? So things like That's lied about diabetes. You want to make sure that you are healthy and your BMI is being maintained under 25. So speak with your doctor about ways to make that happen, whether it's increase in your exercise. And I know it's kind of difficult now. A lot of people might find it difficult to leave the house depending on their age, depending on whether or not they're vaccinated. Um, and even still, I think there's a bit of a concern about getting ill with COVID. So some people, and I've seen it in my practice, have been gaining a little bit of weight. I want to make sure that we try to employ strategies that can be done in the home so that we can maintain fitness and therefore prevent things like colon cancer, heart disease, diabetes. So definitely smoking cessation is a big deal. Definitely avoiding alcohol. There have been some reports that aspirin might be protective, but we don't routinely advocate for initiation of aspirin. Stay away from anything that's like processed meats and things. Those are toxic things, toxic foods, and really should be, if are going to be consumed, they should be consumed very, very sparingly.
Thanks so much. That concludes our Q&A. I'm actually going to pass it over to Candace to close us out for the day. Candace?
Okay, thanks.
Thank you both so much for having that important conversation. And so with today's event, just wanted to share that this is part of the Florida Department of Health here in Miami-Dade, the Office of Community Health and Planning, the webinar series Healthy Happens Here. And as a reminder, each month we hold a variety of different topics, including nutrition, mental health, tobacco cessation, and chronic disease self-management. And we just wanted to share, stay tuned for some more future events for this month of March and upcoming April. And finally, please make sure to visit healthymiamidade.org to receive the latest updates from the Consortium for a Healthier Miami-Dade, as well as other health educational information. And we'll also be sharing right now in the chat the evaluation link just to share any feedback that you have for the future development of different webinars. And so we just want to thank you all again for joining us today and Dr. Jimenez for presenting. We wish everyone a great day.
Thank you, guys. Thank you for coming.